And freaking perfect chicken.
9 o'clock, remember, respectful of everybody's time to get started. Good morning. Welcome to Union Hospital. August 13th, A&R, for those of you online, when we're done here, there is a QR code and a link for you to go out and ask some questions, so you can so I know you're there, and then when we put this out on YouTube, that has the same way, that way I can keep track of who gets the opportunity. If you're in person, please be sure and sign in, get an agenda, and there's another handout out there also where someone want to talk about, well, so we're gonna get right into it. So Will Losey's gonna come in, he's gonna talk to us about Union Hospital Clinton, STEMI, and stroke report.
You guys will have to bear with me a little bit longer than normal. I'm doing STEMI stroke from up north and then the STEMI for sure.
You wanna explain to him why?
Yeah, so for about a year or so, I've been the chest pain coordinator for Union Hospital Clinton. About 3 months ago, I've accepted the chest pain coordinator role for all of you as an umbrella. I'm gonna be seeing a little bit more of my face. So the first one we're gonna talk about, we had a 53-year history of CAD, MI, neuropathy, smoker. Dispatch was called out for a diaphoretic patient with chest pain. UMS notified at 23:26, arrived at 29, parted at 43, arrived at Union Hospital Terre Haute at 9 after. So on the run report. There we go. Patient was found sitting on his porch, nasal cannula with portable oxygen upon their arrival. Continued to be having chest pain, radiating up into his jaw. He's known to be very diaphoretic and having some difficulty getting sentences out. Pain had started 20 minutes prior to calling 911. He was laying in bed when it started. Assisted to the cot, further assessed, IV established. 12D shows inferior STEMI. Patient was given 324 of aspirin. Nitro was withheld due to severe involvement. Pain was rating pain out of 10 out of 10, 50 mics of fentanyl given for that. Multiple attempts to utilize eBridge for notification, but however, due to their location, we're not able to, ended up having to call by phone to the Terre Haute ED. Patient was monitored throughout and taken to a 23:56, cardio was paged prior to the patient's arrival. 11 after they arrived, EKG was in the ER, again showing inferior STEMI. Patient went to the cath lab at 35 after and was open at 55 after. So first medical contact, reperfusion of 86, door balloon of 43 on that case. You guys can see the images, what was reopened. So 99% in RCA there. So highlights, opportunities on this one. They noted difficulties with eBridge. This was a run from Park County. There's just a lot of dead area out there. Not much we can do about that. On this one, they did note that they held it for inferior STEMI, but at least did not document if they did a right-sided EKG to see if there was right-sided involvement or not. Second case is a 67-year-old male. Hypertension, cardiomyopathy, history of stroke, CHF, and TIA. 911 call was made from the patient's place of employment, complaining of lost control of his left arm and slurred speech. EMS was notified at 11:45, arrived on scene at 56, at 12:06. That was 10 minutes. I'll talk about this a little bit more, but we started doing some more goals around stroke runs. I've got a slide in here to show that a little bit later. That's one of the goals. And they arrived at Union Hospital Clinton at 12:30. So upon arrival to the main office, 67-year-old male, conscious, alert, seated in the back of a pickup truck. Worked up at Rockville Lake there, I believe, or not Rockville Lake, Chucky Run, working as a groundskeeper there. Went to activate it, couldn't move his left arm. Initial stroke assessment showed a flaccid arm, slurred speech, and minor left leg weakness. assisted to the cot. Stroke scale was performed throughout the transport with no resolution of his symptoms. IV is established. Patient A&O, transient confusion, still had the slurred speech. Didn't have any other complaints, 12 lead on the mark. And they did activate a stroke alert prior to arrival, taken directly to CT. So they arrived at Clinton at 12:33. Stroke one was called by the team and taken directly to CT. At 12:39, teleneuro was engaged. And they began their consult at 12:50. Team K at 13:06. So a door to needle 33 minutes on that case. Arrangements were made for transfer to Union Hospital Terre Haute post T and K. This was the day, I believe in June, that big storm hit Terre Haute. So that ended up delaying the transport, getting the patient out of the ER and up here where neuro could see him. Did have a repeat CT of the head the following day, didn't show any new infarct or bleed. They did have a transesophageal echo to evaluate for a PFO that was negative. They got discharged on the 27th without any deficit. So December of last year, AHA put out an article outlining different things that they had identified in an EMS chart that led to a quicker door to needle time. So as our 2024 stroke team goal, we wanted to mirror the STEMI feedback that we've been giving out. Hopefully you guys have all been getting those. Doing the same thing with stroke. And we took the 6 data points that they had in their article. So arrival to departure from scene in less than 15, documenting last known wells, stroke scales, pre-notification, glucose results, and placing an IV. And then they did education with both Ileana, Park County, explained to them why it is that we're doing this. I think I've done 14 stroke activations since then. I will say that it has opened up some engagement with EMS on why we do things. I think one thing we kind of take for granted is you guys know your role, I know my role real well, but we don't necessarily know how those mesh and how we can better integrate with each other to have the best possible outcomes. So that's what this is geared around. So that's why I threw that little time goal in there, just to touch on this. So on this case, they had both Cincinnati stroke scale and VANS charted, pre-notified, clear documentation of last known well. We did fall outside of the 30-minute goal for our T and K on this case. The only thing that we identified was that the teleneuro discussion, and this was felt by the entire team in the ER, was extremely thorough and very well explained at length. T and K was in the room and under that 30-minute goal, but can't get it until you get that order. So not much we felt we could have done there. And we got a STEMI case for up here in Terre Haute. 82-year-old male, history of prostate cancer, CAD, hypertension, high cholesterol. Call was made 911 from the patient's PCP office. Came in to see his doctor after a 3-day history of chest pain. EMS notified at 8:31, arrived at 38, departed at 50, and arrived at Union Hospital Terre Haute 9:02. Upon arrival, crew was met by physicians stating that they had a patient with chest pain for 3 days, elevation to ABF. Patient was pink, warm, dry. Only complaint was that of chest pain, 8 out of 10. Taken to the ambulance, did a 12 lead, showing again that inferior EMI, given 325 of aspirin by the PCP office, and there was no change in the pain with the aspirin. 12 lead was transmitted to Union Hospital Terre Haute ER. STEMI alert called. They did check for the posterior involvement, and luckily this patient did not have it. And they're unable to get an IV established with the patient, unfortunately. So 901, cardio page prior to arrival. There's a theme there. We're going to talk about that here in a second. 906, patient arrived in the ED at 8 EKG repeated, began showing inferior STEMI. 27, patient arrived in cath lab. 54 after, they were ballooned. So first medical contact reperfusion of 74, door to balloon of 48. So blockage up there and the improvement in the caliber of the vessel. They got it reopened. So this one was checked for right-sided STEMI involvement with that inferior MI prior to nitro. all-time goals were met. Last slide here is a request on my behalf. So as Barry mentioned there, I've kind of taken over as the chest pain coordinator. So we're always looking at ways that we can improve, things that we can do differently. The ACC came and did our accreditation visit last year. One of the recommendations that they made was that we do more activations of the cath lab based on EMS alerts, which is something that I personally am passionate about. I think that's something we should be doing every single time. I can tell you that Steph Laws is working with cardiology to make sure that they are all on board with that. One thing that was identified last time we spoke about this was that if you're utilizing eBridge to notify that in there, if you guys could throw in the cardiologist somewhere in there so that they know who they're paging, right? Because Providence and UAP, they are currently seeing their own patients. One of the ideas that we're trying to work out with them is just a universal STEMI call doc, which would eliminate that altogether, but that's something that we're still talking about. So, but one thing that I want to do so that I can present some actual hard numbers is I want to look at what the difference is between your guys' activation and when we're actually putting that page out for cardiology. When I went through this, so currently, first medical contact reperfusion, this is all STEMIs. We're at 99.1 for EMS with a goal of 90, so we're close. But, you know, so we're talking about 10 minutes here we're trying to save. 6 charts of the 18, I couldn't find any activation time in there, so I just did a couple screenshots here of things that I was able to pull, whether it be your 12 lead transmission time, or there was a couple different places in various, I know you guys' charts are all different, where you're trying those activations. If your EMR doesn't have a place like that, if you could throw it in your narrative for me, that we sent the activation at such and such time, just so I can show them, you know, hey, EMS is saying they have a STEMI here. We're telling the cardiologist we have a STEMI, figuring out what that time gap is. Right now, I've seen them anywhere from 4 minutes to, I think, 17 minutes as far as time lag. You know, so if you average that out, we're pretty close to our 90-minute window, right? In theory, I know it's all not the same when you're calling people in. But if we can get the cath lab team and the patient on the road going to the hospital at the same time, then we're going to save heart tissue is the end goal. So you guys can knock that out for me, I appreciate it.
It will.
Yep.
I just, for some of the stimulant times, I will say, I think if some of our crew members are utilizing like the radio to make a stimulant, that time may be a bit of an estimation.
Okay.
So that may be some of the reason that there's some
Right.
differences there.
And I know that because I talked with Julie a lot of Park County, mainly about their connectivity issues, and we've looked at that, and so when the eBridge app, when I get in there and look, I can see the difference in when it actually hit versus when they sent it, you know, based on their documentation. So yeah, there's issues, but we gotta at least start collecting the data to know where we're at, right?
Thanks, Will.
Thanks.
Next up is gonna be Beth, to do Union Hospital's stroke report.
Good morning, everybody. How are you guys doing?
Good.
Now I'm terrible with text, so if I mess this up, please forgive me. Okay, my glasses, so I can see them.
You'll be on, it's just one arrow.
First, I just want to start out and let you guys know that Union Hospital, we had our certification visit with ACHC, and our stroke program was reaccredited for 3 years. So thank you for that, for your help on that. I also wanted to share that recently we were awarded with the American Heart Association Get With the Guidelines Stroke Award. We received the highest award that a primary stroke center can receive. We got Gold Plus, Target Stroke Honor Roll Elite, and Target Diabetes Honor Roll. And I want to say thank you to you guys, because those times, those ER times that we can get things done here in the hospital, start in the field with you. So I really do appreciate all of your hard work on that. And last year, this is top decile performance, that 79% of all the TNK eligible patients that came into Union ER were treated within 30 minutes. And that is amazing work. And a lot of that starts out in the field with you guys that lets us achieve those goals. So thank you. That's pretty amazing work on all sides. This patient was pretty interesting. She came in, she was a 52-year-old patient, an EMS, I'll tell you this. She's a 50-year-old patient with a recent hemorrhagic stroke with right-sided deficits, and her family, I think I missed in a page here. Did it not come through?
That,
I know, but sometimes it's weird. My computer is like
yeah, I
so
copied
weird.
them all.
I know. Just let me see if I put them in the wrong order. Okay, this is supposed to be, start here. We'll just kind of work this in reverse. Let my brain work that way, okay? She was a 52-year-old patient with a recent hemorrhagic stroke. This case that we're going to talk about took place like the end of June. Her hemorrhagic stroke had labor Memorial Day, so she wasn't very far out, but she was back to work and driving. She did have some residual, a little bit of right-sided deficits, and her family states she's on blood thinner, but it was never documented in the ER or through EMS what blood thinner she was on. I'm guessing the family didn't know. Our response time, her last known was around 1700. Her family had talked to her when she left work. EMS was notified at 1812, dispatch at 1813, en route at 1814, on scene and outpatient at 1818. They were dispatched to a local highway for a motor vehicle accident with injury. Upon arrival, they found that the patient was being stood at an upright position held by two passerbys. And they were told that she had jumped from her vehicle at a high rate of speed, said she was going about 70 miles an hour. The patient was alert to verbal stimulus, but unable to answer any questions and appeared really confused. So at that time, they thought it was probably a head injury. So EMS did do a physical assessment for trauma. They did all the trauma workup, put the seat collar on, put her on the backboard and all those good things. On her physical assessment, it only showed bruising to the right lower quad. However, her neuro assessment, she was unable to move her right or left leg. And about that time when they were out in the field is when the family showed up at the scene. Her husband showed up there and said, oh, she had a stroke. So then they started changing their mind to trauma, stroke, didn't know what was going on with this patient. They said the stroke scale was as positive in the narrative, but there was no further documentation that the VAN or the Cincinnati pre-hospital stroke scale was completed. I imagine it was, but I think they were so into the trauma of this patient, which I understand, that it was probably just not documented that way. Her vital signs were stable and all trauma protocol was followed. Union ER was notified via IHERN of an altered mental status and stroke alert. They departed scene in 1832. A stroke alert was called to the hospital in 1837, and they arrived in 1845. In the ER, level 2 trauma was activated. CT of the head was done first in 1912, and it was negative for a bleed. Glucose was 160. They did all the trauma scans, and in 1846, there were no traumatic injuries found on imaging. They're like, did she really jump from a car? About that time, her family showed up with pictures of her vehicle where her truck was pulled over and in park. So they think she was probably speeding down the highway, stopped, tried to get out, fell, and that's what the passerby saw. Family stated the patient did experience a hemorrhagic stroke a month prior, but she was recovered with minimal residual effects. At 2022, she became unresponsive. We totally neglected the right side, and they did a CTA. And at 2120, it resulted because they did a CT perfusion with it. And it showed an abrupt occlusion of the M1 and proximal M2 segment of the left MCA. So if you're thinking MCA territory, put your hand about right here, and that's about the territory of the brain that's affected when you have an MCA occlusion. So a large territory of the brain is affected. The CT-A was positive for that infarct, and they went ahead and they did a CTP, which is the brain perfusion, to show how much brain is salvageable. She had a mismatch of 26 millimeters. That was the amount of brain that could be saved. That was the penumbra, and her core infarct was about 12. We do not offer thrombectomy services here at Union, and we could not TPA her or TNK her because of her thinners. So we did live stat her to St. Vincent's. I did lose her on the MAR. the EMR, because we don't see St. Vincent's work. But I did see a further admission where she came back in and her MCA had about a 40% occlusion. So they have done some sort of procedure while she was there. And she was up walking and talking with minimal residual when she came into the ER the next time. So I think that is great work by EMS to recognize that in the middle of a trauma. Because, you know, if you hear someone jumped out of a car at 70, your focus is going to be on trauma. Is it a head trauma? You know, most people would not think stroke. And EMS did, so I think it was a really good catch. And the stroke alert was called. And it was not documented as being completed, but in the narrative, they did talk about the stroke scale, so it was done. I think that is really good. I will say I really like the work Will is doing with Clinton and doing the feedback for every case. But here at Union, our volume is so great. You guys know all the strokes that come in here. I'm also the manager of our progressive care unit where all the strokes go. And you know, it's uncommon for us to have 15 strokes at a time. And between the two jobs, I'm not able to give feedback on every case. But if you ever want feedback on a case, or if I ever see anything that's really great or egregious, I'll try to reach out to you guys. Because I will say overall, I had pulled 4 cases to read through the cases for this presentation, and they all had really good narrative, really good stroke alert was called on every one, and all of them had a pre-stroke scale done. So I think you guys are doing a great job.
Beth, do you mind if I interrupt you for a second? So I'm Phil Jackson, I'm the new medical director at Union.
Nice to meet you.
But this is actually my case.
Yes, it was.
And, yeah, so it's really good follow-up here. But I just wanna, you know, speak to that a little bit. Like, you guys are our eyes and ears in the field, and having that feedback when you guys came in absolutely, you know, influenced this patient's care and got them the CTA like quicker, so that they were able to get to the place that they could actually perform reperfusion. So strong work. I mean, that is like absolutely crucial. If it's not adding up in the field, you know, let us know. You know, like we don't get that contact. So like when that patient, I think it was her daughter, had a picture of her car, there's like no damage to the vehicle. Like she was in park on the side of the road. So clearly she didn't like jump out of her vehicle or crash. So it just like was all around great work. So I just want to say that. Strong work, guys.
Yeah, and I will second that. Thank you, guys. If you have any questions, I'm always here at Union somewhere. Feel free to reach out to me anytime.
Reach out to me and I can get it to her. too.
That's true. Thank you.
Thanks, Beth. Appreciate it. Miss Tina, you ready? Next up is gonna be Tina. She's gonna do our trauma report. Sorry.
Morning. We have 2 cases today. One's from May, I think this one was from July, I want to say. So this was a 59-year-old male, with a motorcycle accident. 911 call came in 1319, dispatched at 1320 and route 1321. On 1323, departed 1340, and at Union ER at 1348. Those decent times. They were on the scene for about 17 minutes. Total 911 call to arrival was 29 minutes. Okay. EMS report, it was dispatched to the scene of a single vehicle motorcycle accident. Person at the scene didn't see the accident, but they came up on it. Saw a patient laying partially under the motorcycle. On arrival, the motorcycle wasn't laying on the patient anymore. Patient was alert and oriented ×4. He had a helmet on, small abrasion to the front of the helmet. Can't remember the accident. Unknown if he actually had loss of consciousness. Manual C-spine while the helmet was removed. cleared and the C color was applied. He was complaining of left rib pain, no crepitus. He was having pain with inspiration and expiration. Left pant leg was wet, so they exposed his left lower extremity and it showed 2 avulsions. Bleeding was controlled. He wasn't complaining of leg pain. He did have a second-degree burn to his right lower extremity. I thought it was from the motorcycle laying on his leg. They rolled him to his right side, put him on a longboard, secured his head, strapped him, and then put him in the ambulance. They started bilateral 18 gauge IVs. His avulsions were irrigated, sterile dressings were applied. He had good sensation in all extremities, but they couldn't get pita pulse in the left foot. So they gave him 2 grams of antibiotics, saline bolus, 1 liter. He was responding, but he was lethargic. At that time, his vitals, blood pressure was 68/40, pulse 73, rest 24. He was 96% on room air. GCS was 15. They called an IHERN. They did call it a trauma alert. Responded, went to Union ER. They put him in trauma 2. Pre-arrival note was motorcycle accident, obvious open tip fib fracture, 6 to 8 inch laceration to the left knee. Pressure was 68/40, pulse 74, level 1 was activated at 13:41. And the trauma surgeon got there at 13:40. He was paged at 13:42, got there at 14:10. So this is our trauma criteria, activation criteria, and he met level 1 because of his blood pressure. He arrived at 13:45, was in a different note. It was a white alert and oriented. They had him in a C color. He was hypotensive with an obvious deformity to the left lower extremity. Systolic blood pressure was kind of bouncing around, was 84 to 130. Heart rate was 78 to 125. Respirations were 18 to 25. GCS was 14. He had a complex laceration to the left lower extremity with muscle and fat exposure. Abrasions to the left lateral thigh, blistering and 2nd-degree burns to the right lateral leg below his knee, bruising to the left shoulder, tender touch on the right hip, thoracic spine tenderness. He did have bilateral pita pulses at that time. FAST was positive for fluid in the right upper quadrant in the blood with improved blood pressure. Trauma surgeon was at the bedside and recommended he be taken to CT. So he had chest x-ray, x-ray of the left knee, left tip fib, pelvis. Something about his femur. CTA of the chest, abdomen, pelvis, CT of the head, CT of the spine. So he had irregularities of the first and possibly second ribs on the left. Irregularities, posterior aspects of the multiple ribs on the left, concerning for fractures. CT of the head showed a small acute subarachnoid hemorrhage in the right frontal lobe. There was no shift, no mass effect. CTA of the chest, abdomen, pelvis, there was traumatic splenic injury with events for contrast, extravasation and bleeding in the perisplenic, soft tissues consistent with a shattered spleen. Which I've never seen that or heard that before. There was a laceration involving the lower pole of the left kidney, small hematoma about the left kidney, and there's numerous left rib fractures, involvement of the 1st through 11th ribs. A small amount of left pleural fluid, patchy opacities in the dependent left upper and lower left lobes, suspicious for small contusions. And the superior, mild superior wedging of the T2 vertebral body and acute in appearance. Minimally displaced fracture of the left proximal fibula. Okay. Soft tissue swelling and with the associated laceration to the mid to left distal I cannot talk. Mid to distal calf, distal thigh and anterior knee. Oh, wait a minute, there it is. Sorry, there was missing the line there. I can't say it. He had some labs done, it was typing screen. So they got a call from the radiologist, scans are notable. I can't spell either. For the following findings, subarachnoid hemorrhage, multiple rib fractures from ribs 1 to 11 on the left side, very complex splenic laceration in addition to the laceration involving the lower pole of his kidney. Oh, should be pole. They gave him another gram of antibiotics, gave him some vein, tetanus, fentanyl. Talked with the trauma surgeon and recommended they transferred him to IU for high level of care. So he was transferred to Methodist at 17:48. Total ER time was 3 hours and 50 minutes. This is a film from a CTA. I don't really know what it showed. I just thought it was really cool. You can make into the scans. I don't know if you guys have gotten to play with them. You can make them go 360 vertically and horizontally. So I told Jackie for Christmas I want one so I can hang it on my desk, play with it all day. But, any opportunities, kudos, discussions?
Anybody remember it? Anybody have it? Check your point. You had it?
I was on the ladder truck with it and he was on a run actually, on Locust, whatever, and he stopped by to help.
Do you remember it? Anyone?
Yeah, I think he basically kind of just like, I think he was just coming off of like 30th or whatever the street was at the stop sign. I think he just kind of throttled it a little bit and popped the curb and hit the tree, and then it rolled a little bit farther and it rolled on him. So it wasn't like he like was going like a super fast speed unless he just kind of throttled it too fast, but.
So that supports a statement I made in a previous meeting. Yeah, so to fracture rib 1 and 2, that's a lot of force. It
Yeah.
takes a lot. Old boy was messed up. And I've done the trauma here for about 7.5 years, and I also have never seen a quote unquote shattered spleen. I've seen spleen lacerations that are very significant. Dr. Jackson's shaking his head. And of course, so if it's like they grade them, was it 1 through 5 or 4? Is it 4? Okay. I know if we get in the 3-4 range, we're like, a 1 or a 2 we'll keep here. There was no question that guy was going. I mean, he was gonna go. But it just goes back to, I know only half of you can see me, goes back to really good pre-hospital. And a lot of you guys I know, and a lot of you guys I don't know because I've been away from it too long, but your documentation helps us put the picture together. So he had a burn. It makes sense, but then you actually tell us that we think it happened because the bike was laying on him. I completely agree. So that tells us that wasn't a priority, right? But then we look at his ribs, and I just kind of chuckles. It's like, well, now we know why it hurt. He couldn't breathe because he literally broke almost every rib on that one side. And to break 1 and 2, that's a lot of impact. So he must have been kind of going a little quick when he hit the ground, is my guess, or the bike come down on. I don't know how big the bike was.
Well, it was because it was just, he came from a stop.
Okay.
So, cause it was like the intersection of Locust and like 30th, so he was from a stop sign and he hit it. So he must have just like hit the throttle too hard and then popped the curb and it just.
Was it a big bike?
Yeah, it's like a Harley.
Harley, okay, so going back to like basic EMT where they're like, think about the mechanism of injury and think about the potential injuries that can come from that. He got them, right? He got about all of them, and it sounds like it kind of all landed on that one side. So really good documentation. I think the opportunities lie with us here in the hospital. 3 hours and 50 minutes is twice as long as it should take us to get somebody out of here. Because honestly, and I don't know the circumstances, you guys may have been on runs, it may have been bad weather. I don't know. Did we fly him or ground him?
He
Flew out. So it may have been, we may have had to wait on somebody, I don't know. But we have a rule here in the hospital of 120 minutes. Well, I'm telling you, a 2-hour time clock goes like that when you're dealing with a big trauma patient. You guys know that. You've stuck around and helped us with that. So this is perfect because you gave us the information. I think that IHERN had pretty much everything on there. I don't remember anything bad. You tell us when it's a trauma, and we know there are opportunities in-house. We get that. And so there are things for us to work on, but this was a really good run. He had exceptional care pre-hospital. He had exceptional care in the hospital. I think honestly, probably the only thing was, we waited too long to get him out of here. And that may have been CT, that may have been EMS, I don't know. I don't know.
I think it was on the note that reading it sounded like it was the trauma surgeon type. He
Was probably trying to decide if he was gonna keep him or go.
and trying to decide, because his pressure was bouncing, he was trying to decide Is he really taking
Did he make it?
She,
We have an
I don't
outcome?
know that.
We don't.
We don't
know.
have access to all those records anymore, and they're not Johnny on the spot with their follow-ups. For some reason, I wanna say he did make it. I think he went to surgery almost immediately over there. But I think, I know this case just because
Yeah,
it was
I
so
looked
bad.
to see if the rain notes in, cause sometimes they'll send something, or maybe you would have been back and I didn't see anything to indicate anything.
Yeah.
So there was mention of a pulseless left lower extremity, right?
Yes.
Cory, you remember, was it
EMS.
pulseless when you guys got to him, his leg?
Yeah, but he could feel me touching his foot though. He had sensation, cause when I was pushing him into the ambulance, I asked him like, can you feel me like pushing on your foot? He said, yeah.
But by the time you guys got to him, the bike was off of him.
Yes.
He either self-extricated or were there bystanders or?
There was someone on scene.
Yeah, there was someone there, but I don't know if he crawled out from underneath it or what. No one really told
But
us.
they were able to get them here immediately, but they couldn't. On the left,
So there were
on the screen.
two huge flags that made this a level 1 for us. One was the pulseless extremity on scene, and the other was his pressure. And that's a big struggle for us in-house, is getting our staff, our baby nurses, to see that that pressure of 84 is not good, people.
Yeah.
Especially when you have a mechanism like that.
Yeah.
And then now we know why, because he'd obliterated his spleen, his kidney, and all the other damage he did. So the pressure below 90, man, I'm drawing a blank. I usually have those things memorized. The systolic below 90 for us is a level 1. A heart rate greater than 120 for us is a level 1. And so we see a pattern of, well, but I think that might always be their pressure. Not when they wreck their motorcycle, it's not, or even the standing falls. Those are huge things for us. So giving us that information was phenomenal. The more we get from you, the better. I love it when you guys are like, I have pictures. Yes, please. And then sometimes she'll even put those into the chart because it helps us put the pieces together. And we talked about that in a previous meeting. It's like, we're not there. I don't see it. And you guys that have been around as long as I have know that I've had 30-mile-an-hour crashes that have died, and I've had 70-mile-an-hour crashes that have walked away. And so, especially a motorcycle.
There wasn't a lot of damage to the bike at all.
Yeah, so that's nuts.
His body took all the damage pretty much.
You guys did a really good job. I think the opportunities. lie with you.
It's a really good bike ride.
And
If we need the light.
times, if it were.
So I guess my only potential feedback here is, that- so we have a open fractured obvious to the left lower leg and it's pulseless distally, right?
That's it. Yeah.
Okay, so I'm wondering if a tourniquet should have been applied there. I'm not, I
There
don't know.
wasn't any major bleeding.
There wasn't any bleeding.
No.
That's fine.
Yeah.
It was just, you could just see, I mean, the fatty tissue and stuff, but there was no major bleeding.
Okay. Yeah, and then, you're fine. But if
So
there was
with
a lot of bleeding, the low
With the
threshold.
fire department, their scene times are so short too. Their transport times, of course, like, even that one, I think.
We were only on scene so long with that one, just because trying to get him on the backboard and make sure he was stable and stuff before we left the
Like,
scene.
Transcare in these outer areas, they have a lot longer transport time to us, so they have antibiotics in their protocol. I can't tell you exactly what, is it like?
Yeah, we started Cefazole on him.
Yeah, they gave stuff, I mean, and that's why I wanted to use this, because they did a great job documenting even that they did manual support while they took the helmet off, but all around. They put him on the backboard and they recognized open fracture and gave him the antibiotics. That saves us tons of.
I didn't take it off. I didn't.
Right thing to do for the patient.
So our scene time goal is 20 minutes, and I will say the fire department is averaging about half that, and that's long ones. They, just because of geography. Now, Transcar has to deal with a little bit more, or, sometimes they get into these weird areas where they have to extricate or access to the patient or something, but that's actually, for the fire department, that's actually a very long scene time, but it's still.
Traffic accidents are less, especially with major
Yeah.
traumas, but that one was just a different instance, like trying to.
Yeah, we
I feel
find evidence to support that, and then we're like, oh, the evidence is 10, so we didn't, Lori found that for us. We didn't push that a lot. We used 20, but you're right, the sooner you can get them to us, the better. And telling us ahead of time is perfect, because then we can get a lot of times we can activate that trauma surgeon for level 1. We can activate them before the patient gets here. And they're judged by patient arrival so we're level 3, so they actually have 30 minutes, but we rarely take 30 minutes. If we do, it's been a communication issue. So by you guys telling us that, then we can activate them sooner. So that was a good help too.
Anything else? We'll go on to the next one. This one was from May. This was a 47-year-old female, inhalation injury, fire accident, jumping from the building. 911 called at 12:46, dispatched 12:46, about 12:46. On scene 12:54, departed at 12:59, and at Union ER 13:59. Biggest time was departure to arrival, so in out arrival, 8 minutes on scene, 5, depart to arrival at ER was 30 minutes. So that one call to arrival was 43 minutes. Excuse me. So this was dispatched for a 47-year-old female jumped out a 2nd-story window. They estimated 15 to 20 feet from a residential fire. There was obvious black smoke from the window. She was found on the ground complaining of severe right hip pain, didn't want to move her leg. Obvious black suit on her face, tongue, and the back of her throat, redness and slight swelling to the right side of her face. She had no stridor, no hoarseness, denied shortness of breath, denied neck pain. She was alert but slightly confused. Blood pressure was 108/56, heart rate was 126. Rest for 22, SAT was 98%, GCS was 14. So they advised their dispatch they needed a helicopter. They said the ETA was 25 minutes, so they disregarded. Placed on a cot, loaded in the ambulance, put her on monitor to 4-lead, IV, 1 liter normal saline. So en route, her pain was a 10 to 10. She had rapid breathing. They gave her IV ketamine, relieved her pain, but then she started having difficulty breathing and speaking. So they pulled over and they did RSI, with successful intubation as with a 7.0 PT tube. IV went bad in transit. She was coughing over the tube, but I think they were almost here at that point. So they called IHERN, took her to, and she was taken to Union ER. Pre-arrival note said structure fire, jumped from 2nd-story window, blood pressure 193/112, heart rate 132. SAT was 100%. She was intubated, sedated. She was a level 1 activation at 13:25. Trauma surgeon arrived at 13:32. So she arrived at actually 13:34. Their temp was 37.3, heart rate 120, rest 25, and blood pressure was 125/82. She was on the vent at 100%. She had singed nasal hair in the oropharynx. They started 2 more IVs, put in a Foley, put her on, put a C-color and a pelvic binder on in the trauma room. She had bruising to her right hip. I gave her some meds, more IV fluids. They did labs. Her white count was 16. Glucose was 388. Mag was normal. Alcohol was normal, but her drug screen, which I did not know until I went back and reviewed it again, I must have missed it, but she was positive for methamphetamines. UA was positive for proteins, blood gases, pH 7.355, PO2 was 239, PCO2 was 41, so that was 100%. The carboxyhemoglobin was 11.5. X-ray of the pelvis showed minimally displaced fracture of the bilateral superior and inferior pubic rami, and chest X-ray that it was in the right mainstem bronchus, said to retract it, and it was done. More left than right by bilateral basilar opacities, contusions maybe. CT of the spine, no spinal fracture. CT of the head, she had a right frontal subdural hematoma measuring 6 millimeters. Right frontal scalp swelling with mild mass effect and mild narrowing of the right frontal horn. And then the CTA, the chest, abdomen, pelvis, minimally displaced fracture of the right sacral ala. I don't know what that is. I know what that is.
What?
It's the, like,
Go ahead.
go ahead.
No, go ahead.
It's like the pelvic wing there.
Yeah, it's a wing. Allah means wing.
There you go.
There you go. Thank you.
That
was Mark.
Yeah, a minimally displaced fracture, bilateral superior inferior pubic area. And then a diagnosis, inhalation injury, fire accident, jump from burning building. She was transferred to Eskenazi, a Lifeline at 15:07. Total ER time was 1 hour and 33 minutes. Times were good. The opportunities, kudos.
You remember that one?
Star.
That's what I thought. It was one of the.
It was, but
So, ABCs, right? So, we could explain the injury. She jumped from the building, so it makes sense. She probably landed on her hip and the small bleed and all that stuff. But they actually did a really good job recognizing that the airway was critical, right? Because burns, we don't do burns here. And when we have burns, they're big, right? And we know, oh my God, this is not gonna stay here. So the times were really good. They did a really good job. I think it actually says they pulled over to intubate. So I don't know if maybe, I don't know the medic. I don't know what's going on, but kudos. And so they got the intubation because once that airway starts going, it's gone, right? In a burn patient. So they recognized those things. I remember this being like a really weird situation too, if I remember right. Like
yeah,
it became like a news story and
there
stuff
was
too.
a lot of
and-
questions about.
So,
Yeah.
I don't know. What do you think?
Yeah.
Was there anything we could have done better here? It's hard when you're not the medic on the run, isn't it?
That's
great work at the
rig.
What'd you say, Ash?
You can tell her, like, the whole stress went down though with her vital change and everything like that. It was
Right,
Amazing.
so there were several triggers there for us, the respiratory compromise, the intubation, heart rate, I think was greater than 120. And like she said, we didn't, at the time, we talk screen everybody, that, we live in ER, you're guilty until proven innocent in our world, but, it wasn't a priority. We didn't think she jumped because she was on meth, but she jumped because her house was on fire, right? And,
From the meth, I'm sure.
yeah, I'm sure.
I'm sure.
If you get the news story, because I'm almost positive they were cooking meth in the house, which is what caught it on fire. But her injuries, her traumatic injuries could have easily become a distracting injury, but they didn't. This medic, actually did a really good job, kept the priorities. ABCs come at the beginning of the alphabet for a reason, right? Because if you don't have an A, the B and Z don't matter. And so they got their airway, got their lines, did what they should do. We obviously panicked when we get a burn too, because we're like gone in an hour and 33. So no, I don't think that's it. I think we just had really good care on the scene, so.
No, it was really good. The only thing I thought to mention was, that we put the CPR and the pelvic binder on her here.
Right.
It could have been that, and if you stop to think about the mechanism of injury, even though luckily she didn't have any, you don't know that until you know it for sure. So sometimes jumping out the window.
I think they probably got on scene and puckered a little bit more than usual and said, let's go. And I think because
And
the
that
intubation
could've
was en route, the IVs were en route, and I think they just focused on that. But like I said, it's
They
just
were both really
speculation.
good cases, so.
Thanks, Neil.
Thank
Appreciate
you.
it. Next up, we've got Craig Kenny, State EMS Director. He is going to come talk to us about some consents and pre-hospital work, some SORs, some things like that. So appreciate it. Thank you, Craig.
Good morning, Craig Kenny. I'm State EMS Director. For those of you who don't know me, I've been in EMS about 35 years. I'm a paramedic and primary instructor, and I'm also an attorney. So I often talk a lot on documentation and legality issues. And I will say, I think this is interesting as I sit back and listen. I always enjoy hearing different audit and reviews. I think it's nice you mix the hospital with all of the pre-hospital, because sometimes we do them separate. I feel like we don't always have a connect. And you also see sometimes what EMS experiences where like you can't get St. Vincent and so you're out of that loop. Well, sometimes EMS may not always be as connected to the hospital. So I think that's excellent. So a quick review of the basics of consent. Each person has a right to control your own body. None of us want a situation where, let's face it, the whole movements on harassment stuff, someone can't just come up and start rubbing your shoulders, whatever else. We need to always remember that when we begin treating a patient, just because we think there is a need, we can't force ourselves upon the patient. So we have to have some kind of basis that we can go ahead and treat. And the first one is expressed or informed consent. And that's a conscious patient allows treatment. And I always joke when I teach my EMT classes, when we go in, I say, hi, I'm Craig from the ambulance. Do I ever say, I would like permission to begin treating you? No, let's face it, I just say, all right, we'd like to take your vital signs. So I don't really say, can we? But yet, you know, they could be like, don't touch me at that point if they want to. So I don't think it has to be formal, and that's why it is, can be based on their actions and looking at that. Does have to be a rational one, so they have to be oriented enough to make a medical decision. That probably applies more to if they're doing a refusal, when we get to refusals. Because on treatment, if they aren't rational, that could be the basis for why we begin to treat. And then it has to be informed if they are making determinations about their care, meaning they have to know the risk and benefits of what's going on and be able to comprehend that and make that determination. And again, it can be by verbal or can be by their physical action. So if you say, I'd like to start an IV, can I see your arm or something? They roll out their arm. Have they really said, yes, you may start an IV? Not really, but they've agreed to it. And you can go ahead and proceed. Implied consent actually is usually easier. Implied consent occurs particularly in an unconscious patient. And the presumption is they would want treated. So if we have someone collapse here, we would not have a discussion. You know, we wouldn't take a vote. How many people think we should go ahead and treat? What? We would jump in and we would start treating, and that's implied consent. There may be other circumstances for implied consent, which would include impairment, such as a stroke patient, diabetics, things like that, that maybe can't make that rational thought, but the assumption is a normal patient would want to be treated. And again, others cannot decide for the patient unless they have a legal relationship like a guardianship, and or a parent, for instance, of a minor. But yeah, you cannot decide because sometimes, let's face it, we get in and we have a 70-year-old that's alert and oriented, and they're like, I don't want to go to the hospital. And their daughter or whoever is saying, hey, this, you know, I want mom to go, make her go. Well, really, mom has that determinant unless she is incapable of making that decision, or unless the daughter is actually a legal guardian. Minor consent is anyone under the age of 18. There's unconscious or life threats, then if a minor would create implied consent, so you don't have to have the parents to do immediate life-threatening care. And if it's any other type of emergency, you do need that consent. When in doubt, I always encourage transport of these patients. The hospital is probably going to be more conservative. You know, they may want a court order before they do certain types of treatments, but I have never heard of a case where EMS has gotten in trouble or sued because they transported to the hospital when it was kind of a questionable nature. Custodial consent would be a third-party consent, and the examples of that would be particularly in like the prison setting, but let's face it, I saw a bunch of school buses driving in my area up in Indianapolis. Schools started, schools also are custodial consent, so that means until a parent arrives, they control the medical decision of the people that are under their care. This is emancipation. There is a statute in case you want to know more. And for emancipation, then you have to have, first of all, I would note, it is a legal process that people determine. So in my EMS career, I think I've truly seen like one or two that are truly emancipated, because the rest say, no, I am, because they fit some of these categories, but they never actually got emancipated. The challenge is that's the black and white law, and me as a provider, I know it's a gray area when we're out there. So if they fit some of these and the parents aren't involved in their life and they happen to be 15, and that may be a determinant that they can determine their own healthcare decisions. That one, consent for incapacitated adults. There is actually a statute as well on that. And this is probably where hospital legal would come in and determine, and it's kind of like a tier structure, who else can make the determination. And I think if you look at these, most EMS providers are probably not shocked, because we probably have accepted from these if the patient's incapacitated. particularly a spouse, but, you know, a parent, it could also be a child. And so it's people that have a close connection, but the law actually supports that. That's why I wanted to include that in. So when do we, get away from consent and there are no consent? Then persons that may not provide consent are a spouse who's legally separated or filed for divorce. So obviously, I would say if you get to a weird circumstance and you have someone, and we just had the house fire example, you know, if there's suspicious circumstances and you have an ex, and the ex like, oh, they wouldn't want to be treated in this, well, I would be very suspect, be like, no, we are not going to accept that. And individual subject to a protective order. And so obviously if it is, and you sometimes see that in a parent-child relationship, but more common in a domestic spouse or relationship. And individual is subject to criminal charge, which the individual is incapable of providing. So that I would go back to that may even involve when it says subject is, you know, if you have suspicion that they've been involved in a crime with that. There is immunity for people that are listed if they make a decision. So if you are questioning, and most time our protocols take over, I would probably follow protocols before forcing a spouse to make a decision. But if they're like, well, I don't want to make the wrong judgment call, and I doubt, of course, they're going to be sued by their spouse. But there is protections from criminal prosecution, civil liability, and professional disciplinary action if the provider makes it in good faith. And actually, I think this one's interesting because I think this could apply when you look at the last one, professional disciplinary action. This one could apply because every now and then we get complaints and we will look and it's an off-duty EMS provider and I'm like, what are they doing? And I'm scratching my head, you know, because they don't act rationally when it's their own family member. And so I think if they're kind of mistreat an EMS crew or something, then the question would be for the consent part of it is, were they acting in good faith based on the relationship with that family member? Disclosure of medical information, and you can share medical information relevant to healthcare and what you are trying to do. So I would not go into their whole medical record unless you know they have a release. But if you're trying to make a determination like which hospital to go to, then yes, by all means, this is a potential tibia fracture. We need to go here rather than just be like, well, I can't tell you what's wrong. There's something wrong with the leg. No, you can go over that if you're trying to have a discussion about the healthcare. This is always one of my favorites. You respond to a motor vehicle, two-vehicle accident, minor damage, no airbag deployment, seatbelts were used. 17-year-old female does not want to be transported. Can you physically check her out, you know, like do a welfare check? And then the second part is, can she legally then decide if she wants care or not to be transported? Thoughts?
Yes, she can provide a courtesy check. No, she cannot legally refuse unless she's emancipated.
These, and I love these, this is a weird area of the law because we let people drive at 16, but it does go back to what is the age of that person. And so with that, she has not reached the age of majority. So technically she can't make healthcare decisions for herself. So it either needs to be the parent or it would need to be someone that falls within that hierarchy, you know, like an older sibling, things of that nature. And so the age of consent is still 18. And again, we have the emancipation but they would have to legally file for that. Sorry, I merged a couple of lectures here, so a couple of
Is
reasons.
it their burden to provide the court document stating that they're emancipated?
If you want the true legal, probably, but I would just ask them, have you gone through a court proceeding? If they're like, yes, a court, then I would accept that. You know, could they be lying? Yeah, but I don't think you have to have them go dig into a safe and find that, but I think you can ask them, have you legally gone through a court proceeding?
But if they lie to you, then you're covered, right? So
I'm
you
sorry.
can, you document, I asked this question, this
Yes.
is what they told me, and
Yes,
then you're covered, even if they lied to you.
yes.
Okay.
And the only exception I'd have is if you had a, again, it goes back to good faith, as long as it's good faith. You know, like if it seems like they're making it up and setting off red flags, I would not rely upon it.
Yeah, all of it.
So the other one you run into, so I had that accident 1 years ago. And that is a weird one because we could not reach the girl's parents. And, you know, the girl was like, I'm fine, you know, and she agreed we could check her out. Everything seemed fine. Of course, very minor mechanism injury, so very little risk. And so what we ended up doing, and we made a judgment call, was she had an 18-year-old boyfriend that was driving the car. She was a passenger. And so I asked, do your parents know that he is picking you up, you know, from school? Yes, they know that. So we allowed him to make the decision on transport, because my thought was, if the parents know and they've authorized her to be in the car alone with him, that's really kind of a form of minor consent. But sometimes it's hard to analyze those. I also remember another one, and it was a very weird one, and I got called out as operations manager. I was still in law school, and I went over, and it was a volleyball game at South Putnam. And a girl got hit in the head hard with a volleyball, has a history of seizure disorders. Well, afterwards, like a few minutes later, she suffered a seizure, but came out of it. And so the school said, they called the ambulance and said, you take her, and she's like, I'm not going. Well, of course, her best friend, to be helpful, called her dad. And so her best friend has dad on the phone. He's like, no way, she's not going to the hospital. And the school's like, we're not taking her, because we're not, they was actually from Sullivan, I think. They were like, we are not driving all the way back to Sullivan, you know, where she may seize again. And we went through, it was just a horrific nightmare. Thank goodness there was a mom that was a nurse that had driven separately from Sullivan. And she's like, if it's okay, she can ride with me. I know what to do. I know where the hospitals are. I can stop if I need to. So we explained it to Dad, Dad authorized it, and that's how we ended up resolving it. But we were in a weird quagmire because we had a dad say not to transport, and then the school's like, we aren't going to take them. And so it was very bizarre circumstance.
Sir, your thoughts on law enforcement, if we can't get a hold of any immediate family, law enforcement listening and making the decision for a signature?
It depends on the case, and I think we have some slides about that coming up. It depends what's wrong with them. If it's a minor, I think absolutely, because what's gonna happen if you left, they're gonna assume responsibility. And so I would be comfortable most of the time if you're talking about minor.
Yes.
Yes, on the minor front, yes, I think that would be a good call. It looks like we are up to it. Emergency detentions. And so then Barry and I were talking because they switched the statute a little bit. We used to have something called an immediate detention, an ID used a lot in Minneapolis, but not always used in rural communities. And essentially allowed for certain mental incapacities, then you could take a person against their will to an emergency department to be evaluated, and as a tool for law enforcement. It was its own statute. What happened was it was bumped into emergency detention. And so it's no longer an ID or immediate detention. It's part of the emergency detention process. But before in the ID, they could hold or take them to ER, and you had 24 hours to resolve it. Now, as part of this, it doesn't really have a time frame, but it allows a law enforcement officer to apprehend, transport the individual nearest appropriate facility. It cannot be transported to a state institution, find one. And so with that, we sometimes get this question, and I go back to custodial consent. It says apprehend and transport. Does that mean the law enforcement officer has to take the person in a law enforcement vehicle? I can see an interpretation where, you know, if you read the fine language, it kind of implies that's the officer. But it, with the custodial consent, then he could authorize it to be transported by ambulance. And I always say, what is the best scenario for mental health? And a lot of times it's not sitting in the back of a squad car with a cage for someone that's already having a challenge. Is it best to ride in the back of the ambulance? No, I'm not gonna argue that. I get that, but we are the best solution that is out there right now. I'm seeing some innovation with mobile integrated healthcare, because if you have a non-transport vehicle, then that's a possibility if your protocols allow to maybe take that person in an even different environment, which is gonna reduce that stress on that individual. Essentially what happens with emergency detention, once they're in the system, then the hospital has certain procedures that they can do to keep that person up to 72 hours to check their competency in terms of mental well-being. And so it's a tool that is out there, but it is for mental health. So you could not use it, for instance, if, let's say, someone's having what you believe is well, maybe you did a 12 lead and you see a STEMI and they're like, nah, I think it'll go away. I'm gonna stay here. You can't ask the law enforcement officer to do an emergency detention, you know, make that person go, because that's what they need. You're gonna have to go to plan B and work on persuasion, bring in a physician a lot of time to explain the true risk. But if they are making a rational decision, even if it's a bad decision, if they are informed, they know the risk and benefits, and they say no, then you have to honor that. And I know I had an EMT that really pushed me. We had a fire chief, and that's before we did 12 leads in the field. So I don't know, but it appeared it could have been to me, been a heart attack. And so I was advising and she refused. I'm like, she is a medical first responder. She knows the risk, and we spent about 20 minutes and she refused. So we ended up getting a release and leaving. I'm going, am I comfortable? No, you know, but in the end, she had that judgment call, and the EMT's like, you should make her. Like, yeah, I'm not a magic god that way. I don't get to do that. I could be sued for kidnapping, so. This is some of the cases that I looked at when I reviewed emergency and immediate detentions. I still consider it valid on the case law for immediate detention because of the fact part of the main provisions were adopted into emergency detentions. But it has to be by clear and convincing evidence. So again, you know, if you aren't convinced the person has a mental incapacity, then really the law enforcement officer should not be acting upon that, or it's potentially as an abuse of that. See, I jumped ahead to my own thing. You know, the STEMI patient refused to go, can you force them to go? No, it's in your power to convince them, you know, that they should go. I always like diagramming our refusals, because you run into this a lot, and it is a tricky area, and certainly one that you could end up getting lawsuits on with that. But there are 4 main triangles that we have, and so I think the no transport, possible refusal, patient does not want to be transported, and you do not believe transport is necessary. That's kind of, if you are not going to transport, that's kind of a gold standard. You know, if you walk in, you're like, man, this is lame while we're here. Why are we here? And they're like, yeah, so-and-so called. I don't think I need the ambulance. Then do your quick assessment and move on. No transport refusal becomes a little challenging. And that is the scenario with the STEMI. You believe it's necessary, and the patient doesn't want to go. So you have to work on your persuasive abilities and try to always remember to go back to what do you need to consent. And so it has to be rational. So if you're already communicating this far along, you probably could determine that they are rational, they're competent, but it has to be informed. And that's the one to make sure that you cover the risk and the benefits. Here's the benefits if I take you, what's going to happen. Here's what could happen if we do not. And if they fully understand that, then that's their right to refuse that transport. The bottom two are transport models. The bottom left there is the patient does want to be transported. EMS does believe transport necessary. That's another gold standard. We all agree, this is bad, let's get you to the hospital. The one on the right is a little bit of a challenge. Patient wants to be transported, EMS does not believe it's needed. The reason I put this as a transport is, if you really tell them no without some kind of protocol or backing, you're putting yourself at risk, for legal action. I do think, again, this is an informed consent. You can advise, and I think you can contact medical control, because they can advise, hey, this is not going to be anything that we can do with this. And I think those would be appropriate with that. But the end result, if they are stomping their feet up and down and you will take me, I would err on the side of taking them, because if you don't, they're gonna be the first ones to complain and take legal action. So, and I'm hopeful and where I see EMS going, I think it'll be nice when we have maybe enhanced 911 centers that can take some of those calls, and maybe they can talk to a nurse practitioner or someone that can kind of triage it, and maybe like mobile integrated health could even go out and talk to the person and really work with them, because some of those people just want to be heard. I guess I'm in my war story mode, but real quick one, I just remember I went on a 5 a.m. one of esophageal reflux. And I'm like, it's already passed, your lung sounds are good, you do not need to go. Well, I'm tired of putting up with this, I'm going to hospital, damn it, and I'm like, okay, get an ambulance, And so I think some of those are hard to do because people just want to be heard because they feel like they've been ignored. Again, any competent person can refuse treatment. And if you have the refusals, we traditionally do that via written form. And the written refusal forms are a form of protection that we have. Doesn't give you immunity if you have them sign a release. No, it's an exhibit that you can use to say, as long as you didn't shove it and say, here, absolutely sign on here, then it is evidence that you were responding appropriately. So there is no immunity for that. This is what it looks like in paper. A lot of times we'll have the check boxes on your newer EPCR forms. But usually you go through and you do a step-by-step process that does an advisement that kind of creates informed consent as well as determines that they're competent. With refusals, again, try to persuade them when you believe there is a medical issue. But if they're competent, they make the final call. You can't involve medical direction because sometimes, let's face it, they don't want to listen to the paramedic, but they hear that it's a physician, and that opens them up to listening to that. And advise the patient that he seek help if there's additional symptoms. And that's something I think is important. If you're signing a release on a potential concussion, I think it's important to advise them what signs, symptoms to watch for when they need to go to the ER. And just as importantly, the final bullet, you have to document that. That's back to your point. If you don't have it documented in there, then later they can say, well, no one ever told me that. And I think if you document it, it's pretty strong evidence that you in fact did tell them that. So why do we document? There's basic reasons, record keeping, medical uses.
Yeah, you can move that.
Trying to remember all of them. There is record keeping, and administrative uses would be the record keeping, like a lot of times, well, we heard the trauma teams, stroke teams, the cardiac teams, they have to do research. And that would be part of education researches, and then the legal issue that becomes, important. For me, as a legal person, you would think I would pick the legal issues. That is important. I actually err inside of the medical uses because being an ambulance service director for 10 years, I know how many times we'd get a neurologist that might reach out and be like, the run sheet's unclear. Is there any way we can check with them? Because I'm trying to make a determination how long the patient has been, with this deficit. And so I know that people read this further down, and I think it's very important that we create a solid record that is part of the healthcare record for that individual.
Click in the screen.
There. So there are basic elements that we do have out there. Um, There are rules out there as far as run reports. I think the key thing that you need to know is that you do have to create a basic run report. And so most EPCRs are going to carry the actual data elements that you need. But if it's on there for a reason. And then there is some documentation essentials, and I think you're gonna chuckle here in a second because we heard it a few times earlier today. We need to have all pertinent findings. So what were the things we saw? Then we need all pertinent negatives. So, everyone did a great job with the leg injury. We want to know about pulses, movement, sensation, things of that nature. And then we need to know everything that was done. I do advise caution on using what I call conclusions. And if you determine that someone is intoxicated versus they appear intoxicated, because of the fact that sometimes those have consequences. If in fact, if you indicate that you believe they were intoxicated and later it turns out they were diabetic, I have seen people that have filed complaints or sued for that because they didn't appreciate being called that. So this is the part that I think you heard earlier, is take a picture. And I think literally, sometimes there's a way to take a picture. I'd say follow department policies. I do some presentations on that. I think it is appropriate in some circumstances, but some providers limit it to organization phones. If you are allowed taking on a personal phone, I think it's very important that it gets deleted after you show the emergency department, because of the fact that it is a HIPAA situation and you should not have that on your personal phone. But essentially be able to also paint a picture with your run reports. We need to know what happened. And if you do that, and that's kind of where you were saying, put the pieces of the puzzle together, they can be like, oh, I see how they were burnt based on the way they described that. And so when I look at the different emotions, like you can't, I'm not good at sketching. I assume many of you in here are not. How can you put this into a run report? So think about it. How can you write it that people get the emotion that you are trying to convey, or more importantly for the run report, what occurred there? Two basic rules. If it wasn't written down, it wasn't done. If it wasn't done, don't write it down. The second one, definitely don't do. We have seen it before for people that have wrote down false things. My favorite one of all time is blood pressures. How many of you think the public knows what a blood pressure is? Like 99% of the public, like in terms of how to take it and such. I would say they absolutely do. And so as soon as you write a blood pressure that you didn't take, then guess what? They're like, they did not take a blood pressure. When I go to the doctor, they put that cup on. They never did that for me. They remember that, but I'm amazed at the people that will just write it off of, particularly nursing home runs, sometimes write it off the nursing home record. And then the patient's like, they never did a blood pressure on me. So don't be writing it down. If you didn't do it, that's falsification. We can actually take action against your license or cert for that. If it wasn't written down, it wasn't done. The attorney in me says that's fine, black and white, but I also say that's not totally true. It's just harder to prove, and so if you don't have oxygen written down, that's not to say that if there's a lawsuit, you can't have fire department that was on scene assisting, say, yeah, we helped put the oxygen on and prove it. It just makes it more challenging to do that. Again, falsification, make sure that it is accurate and correct anything that is inaccurate in that. There's a minimum data set, and just real quickly, minimum data set is basically the required builds that you do. And it helps capture information that is part of what is known as NEMSIS, which is National EMS Database Information System is the NEMSIS part. But it's National EMS Database. We are required to participate as a state, and it is written into our rules. Those are the elements. So these are fields that you should recognize as you have to do on every patient. And if you wonder why, it's because at the national level, they have set it as a priority. Run sheet completion, should do it to its entirety. And if you're doing a narrative, do try to look at spelling and sentence structure. I know not everyone can spell well. If you need someone to proofread that or whatever, that is fine, because sometimes it is a challenge to see. Also watch that you're using only approved medical abbreviations. I actually don't use a lot of abbreviations because of the fact that certain ones have different meanings. What is capital P, capital E?
Could be physical exam, could be pulmonary embolism. Yeah.
And that's an example of one I see a lot, you know, so I think you have to look at what certain ones are repeated, you know, and you could interpret it different ways. Be thorough and be systematic as you, and how many of you write a narrative? And I don't know that we require that. Some areas let them get by with all the electronic. I prefer a narrative because you're going to include things such as advisements or statements they made, and I always quote them directly. You want to capture that in there, and if you are going to capture that, then try to be a little organized as well. And so we go back to, you know, different methods, chart, or however you want to organize it. But like your vitals and your assessment should be together, so that way, if the physician wants to go in and they're looking at neurological status, they should be able to go to one section and find it versus having to pick out where it falls within kind of a disorganized narrative. So what is the deadline to do a PCR? And a lot of times people know the latter one, not later than 24 hours, has to be within the next day. If you actually read it, it says when the patient's delivered, unless it's not feasible. So I always chuckle because I feel like most people are like, well, we have till the end of shift to get it done. And I'm like, the actual rule says, you know, when you deliver. I would say again, particularly two things. One, it is very helpful for the medical record, and they may not, so the sooner you get it done, better. Also, the reason to do it sooner, you're gonna remember it. But a third thing is with modern technology, you're usually sending those electronically. And I think back when I started, we had paper reports. So if you didn't finish it, you had to make a trip back to hospital. So you're like, I'll just save all of them till the end of the shift. Well, now that it's electronic, try to get it done as soon as possible and send it on. So that way you don't have that backlog and you aren't risking confusing different runs with different information. That is the information I have. I'm open. Yes.
And one question, I go back to consent. It doesn't happen very often, but it has happened. We go to the federal pen. The lieutenant at night, when there's no doctor there, they call the doctor. Doctor says, send him out. Patient says, I don't want to go. I don't want you to transport me. I don't want you to touch me. I don't want to go. He's in federal custody and they're like, you have to take him. So what I usually do is I will take them, even though it's against the patient's will, but I will not touch them. I'll do respiration, skin and all that, but I won't touch him because he doesn't want to be touched. So where do the rights fall into that?
If you go back to custodial, then you have the right to do anything. So you can do a full assessment and stuff. I would follow, if that is happening a lot, then I would go to your administration and see if maybe they can talk offline. Because I know years ago at Putnam, we had one, they called us to check out someone and I'm like, and she was known for faking a little, but she was having some abdominal and I'm like, I can't tell. I go, I would send her to the hospital. I'm like, you gotta be safe. And they were like, well, thank you for your advice. We're gonna go ahead and keep her here. And so I called the next day and talked to the chief deputy. I'm like, I don't really think that's a good thing, because I'm like, if something happens now, you have someone saying you should go and you just ignored me. So I think administratively would probably be the best, but as long as they are in custody, federal or state, and they tell you it's invitation, then you can treat as fully as you need to.
Even if the patient says, and they're in their right mind, and they say, I don't want you to touch me.
Right,
They lose their rights.
right.
That's an interesting,
That's
it's an
why when-
interesting
That's
conundrum though, because in the prison,
They're
they
literally in the
refuse
custody
their
of
medications,
federal
they can refuse
They
all.
don't lose all that.
You don't lose other rights.
If
But
you
in
make the-
EMS, they lose their ability to make a choice of where they go. That's not true.
But
But the
if
prison
they,
made the call.
right, but if they can refuse their medication in prison, surely they can refuse anything.
They can't, though.
I can't, like, you have a person down here and you have, I can tell you, when they're in the custody of the federal prison, they can refuse their medications to a certain point. They also can't go on, like, if they go on hunger strikes and stuff like that, the prison has to will force them to eat. Because they are a ward of the federal government. They have absolutely no normal human rights, unfortunately. So like when you have sexual assaults that happen by like staff members to guards to prisoners or prisoners to staff or whatever, they actually are now registered as federal sex offenders, even if it was consensual or not. So they have no rights like a normal human would have. The federal government makes all their medical decisions for them.
And I think, and I will clarify one thing, so I think I would look at what is essential to treating the patient on the way. So I see your point, if it's just riding along and doing some vital, that's fine, you know, if there's an IV that may help treatment down the road. And they're like, I don't want an IV, I would probably skip it, you know, rather than be like, you're in our custody.
Yeah, they have no right.
They did have some.
Jeremy, keep on keeping on.
Yeah, but that's the thing is, it's so hard.
There's nasal verse set, put them to sleep.
Okay, guys.
It's so hard.
So as part of my 2024 EMS goals for the hospital, I'm going to be offering, Union Hospital gonna be offering 3 additional lectures this fall. One's actually gonna be on August 28th. I encourage everybody to try to get, all 3 of them will be in this room. Dr. Yazel's coming on the 28th for the INTOC Summit, and he's just gonna come across over here and speak. He's doing a comprehensive care of a medical cardiac arrest. All these things are gonna touch every level from EMS, BLS up to medic, trying to get everybody. This is free education. It will be done on Zoom also. I'd love to fill the rooms with people. No, I am not feeding you. I'm not doing it. So, bring your own, yeah, bring your own food. So anyway, we have all 3 of them set up. Pharmacy resident, is gonna do one on October 31st, and then, Kent Rusty Baumgartner, happy birthday, Rusty, is gonna do a 12-week presentation, in November for us too. So you plan on these dates. There's a flyer up here. I asked to make sure that you all signed in if you have not signed in. And then,
Hey, Barry.
yeah,
Hey, it's Matt Malamed. Hey, everybody. I just want to add, and thank you so much for that presentation beforehand, but I just wanted to add 2 quick things. Remember that we assess capacity from an EMS perspective, right? And from my book, it's always that they understand as he said, that they understand what's going on. They can elucidate that back to you. They're not intoxicated, or they're not under carbon monoxide poisoning, or they're not hypoxic or hypercapnic. Those are all things that, in my idea, would sometimes diminish their ability to have the capacity to make their own decisions. But when in doubt, and numerous one of you guys already do this, and I love it, but when in doubt, please feel free to call me. My phone number is always available. So if you ever have a question about, hey, does this person truly have the capacity to make the decisions that they're making, or you need a recommendation from my end, call that number. Either me or Dr. Worley or the ED will inevitably answer, and we'll be able to help guide you along that route. So don't hesitate to reach out if there's ever a question.
thanks, Matt. Appreciate that.
Thank you, guys.
Here's the QR code. Fill out the form. Nothing to it this time. It's just basic name, email, service you work for, your PSID number. So that way, if you're online, you fill this out, I'll get recorded and get record and get you on the list for anything. Anybody else have anything else?
You were here, you have to do.
I think that was a great presentation. It's always good to go through that stuff and thanks, Dr. Malamed, for clarifying there. Capacity can be very tough in the field, and so I would err on the side when it's a question to call for medical direction is all, just like Dr. Malamed said. But appreciate all you guys' hard work. Looking forward to working with you, yeah. But I'll meet everyone as they continue to work on here. So looking forward to it.
Thanks, guys. Have a good day. Appreciate it.
Or they try to get us to take a patient, but this patient has dementia. Fine.
Yeah, we didn't actually meet.
Yeah, good to meet you. Yeah, yeah.
Yeah, that'd be great. And
If you
Shut up. Because I don't schedule issues. Still, they have to call right now. Yeah, that's an issue. I understand. Especially if yeah, I mean, I'm sitting there, I talked to you in 10 minutes slightly and on.
You could get that, I think we had one. Right. Go and we call the ambulance and they judge then signs off, they can sign off and they
Then you've got. That was one of the questions I asked.
I call that when I deal with the deal. So I should have seen. All right, I can tell you.
We've got a new. So we've installed it. And
you know, I mean, that goes back to the documentation, like I would probably.
Wait, I see it.
it's